Good morning.
Good morning.
A very good morning to you, Dr. Rosensweet. And as always, welcome to everybody who's coming up, and welcome to everybody who's listening that doesn't come up because I hear from you. And that's always nice. Lots of questions, and we have our questions for today. So may we proceed?
Oh, yeah.
Okay. All right. This question came in stating, I am postmenopausal with every symptom known, save for hot flashes. I'm also in remission from Graves' disease, and I've not having to take meds since 2016. I did start hormones January 16th, and by March had some brownish spotting. I was immediately taken off of all my hormones. We did many ultrasounds, which revealed fibroids, but very small ones. I do have a lot of scar tissue. The quality of my life without hormones is beyond awful, and I want to be back on my hormones. But if I start to spot again, would it be wise for me to force a shed? I only had that one small incident of spotting. They cannot do a biopsy in the office, and I have major concerns about going inpatient. So I am completely confused as to what to do and thought maybe you could shed some light on this.
Good question. Um, there's spotting that can occur in a menopausal woman or any woman, really, that is very understandable and no big deal at all. And I'm going to address that kind of spotting in just a minute. Then there's spotting, and this is much, 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 much more rare, but it does exist. It's coming from an endometrial cancer. In 25 years of treating women in menopause, I've seen two women have that happen. The spotting sort of came out of the blue. We did a transvaginal ultrasound. There was a suspicious bump in the uterine lining. Did a hysterectomy in both of these women. Total cure. There was endometrial cancer there. So I don't take spotting lightly, and yet so many women in menopause, especially those who are being treated with hormones, spot. So I have no idea what the exact statistics are. If I had to make a wild guess in my practice, because I see a lot of spotting every year, I'd say less than 1% is coming from an endometrial cancer, far less than 1%. Yet we don't, in the menopause method, we track that down, we stay with that woman. And here's the most common cause of spotting in a menopausal woman who begins hormones. There's either a little bit too much estrogen, or there's a little bit too little progesterone to balance the estrogen. So we're very scrupulous about how much we know what those numbers are. Like when I look at a woman's estrogen dose, there's a wide range of what's good for women in menopause. But if they're within that range and there was spotting, I would then look to the progesterone and see how much progesterone she was on and assess whether that was adequate, because biologically, physiologically, it's estrogen that stimulates the growth of an endometrial lining. Once a month, every young woman, it's her estrogen output that is the force of nature behind the creation of the endometrial lining that, if she does not get pregnant, eventually will shed once a month. Now, progesterone balances estrogen. In fact, there's a tremendously robust output of progesterone every single cycle in a young woman if she ovulates. If she doesn't ovulate, there's very little progesterone coming out of there. She has to ovulate to produce that robust amount of progesterone. And progesterone is well known to suppress the development of an endometrial lining in a menopausal woman. So the key to the highway here is get the right amount of estrogen, dosage-wise, and get the right amount of progesterone. And you don't really get to know that unless you're doing 24-hour urine hormone tests. That's how we assess whether a woman is getting sufficient estrogen, optimal estrogen, too much estrogen. Same with progesterone, 24-hour urine hormone test. And I'm specifically only mentioning that test because to date, I see no possibility of getting the right, an accurate test with any other of the methods offered to assess a woman in menopause being treated with hormones. Blood tests work really well in a young woman, and saliva tests can assess certain elements like cortisol and DHEA, but I don't accept them for the ovarian hormones, which are present in such tiny amounts comparatively. And I don't accept that urine 5-point test where you're peeing on a piece of filter paper 5 times. Nope, 24-hour urine hormone test will tell us what kind of range this woman is really doing. Now, when a woman is spotting, the first step, and this is what I didn't get from the question, and maybe I missed something there, is did she get a transvaginal ultrasound? Because they should be able to tell. I mean, there was a comment about fibroids. There should be a comment about the endometrial lining as well. And if there's no abnormality in the endometrial lining, it's just an endometrial lining that's formed, I would just go ahead and work with the dosages of both estrogen and progesterone. Of course, my favorite is biased in an organic oils suspension, and progesterone in an organic oil suspension applied topically, or taking progesterone orally, prepared by a compounding pharmacist to micronize progesterone. And you got to get both those right. And women have ranges. You know, you'd think every single man and woman had the same amount of everything that you could name, and it's not true. We're highly individual, and those ranges are wide. Let's say that this is the amount that is the average amount of estrogen needed for a young woman to menstruate every month. Well, that's the average, but some women, they're healthy when they've got a much lower amount, whereas other women are healthy when they've got a much higher amount. That goes for everything you can name. There's always a range whenever we're assessing any biochemical in the body. So that what that translates into practically is every woman has to be individualized in her hormone dosage. And the most common explanation for this woman who spotted was she had too much estrogen or not enough progesterone. I really honor and respect that there's a process in place to assess whether that spotting was abnormal. But that cause is rare, but we always track those down ourselves in the menopause method. So, you know, if it comes down to that the right thing to do is to get that biopsy, there are gynecologists that do biopsies in their office. But if it's the right thing to do to get a biopsy and your only option is to go into the hospital, then you mask up. you booster up, whatever it takes. Because when it's the right thing to do, it's a sacred action and it needs to be done. Now, I do know that that we're in an era of medicine that's so more challenging to navigate. Like when I grew up, for the most part, I'm certainly it's not 100% universal, there was something called the doctor-patient relationship. That still exists, but the doctor-patient relationship, I mean, doctors love their patients and patients love their doctors, not universally, but there was a lot more of it going on. And when I graduated medical school, there was very few doctors that had malpractice insurance. Didn't have to. There was a trust situation going on between doctors and patients. Doctors cared and patients were satisfied, not perfectly, not 100% of the time, but a lot of the time. And then this quirky stuff started happening in modern American medicine and probably all over the world. It's just changed so much And yes, there's a lot of terrific, wonderful, dedicated, devoted doctors, nurses, hospital janitors, laboratory technicians, you name it. There's an army of medical professionals out there. And my God, these are my tribe. I love these people. This is they're laying their life on the line these days. So it's really close to the bone. And there's a lot of great ones. There's a lot of dedicated ones. There's ones who've died because they were willing to serve on the front lines during COVID, for example. Having said that, there's some ones that are very dissatisfied and really stretched to the max, stressed to the max, can't earn a living, and are freaked out and are not happy campers. And there's a lot of them out there. So I don't know how I drifted off into this particular sidetrack, but
You
one,
know, Dr. R, I remember a time when, it was the primary doctor and he was the one and he'd refer out and everybody spoke with everybody. And
yeah,
it doesn't seem to happen like that these days.
I know why I drifted into this because I meet up with patients who have gotten a little concerned by what they were told from their healthcare provider. And as I evaluated the situation, it was an opinion I had that it was excessive, that what they were asking me to do, like I just had a case of a woman who had slightly elevated liver enzymes on a blood test and was told immediately to go urgently to go get a ultrasound of the abdomen. And yeah, you just don't go out and get an ultrasound of the abdomen these days because there's risks in going to the hospital. Well, I've seen so many minor elevations of liver enzymes. Something's causing it. It's usually a medication or a supplement or a strong herb that someone's on. Something's freaking their liver out a lot. But these are very minor elevations. And here's what my thought was that provider had to CYA, cover their ass, because they're subject to this thing called malpractice insurance or complaints where they can lose their licenses. And there's easy access for patients to complain to medical boards. And there's easy access to stick an attorney onto a healthcare provider. So there's this defensive medicine that's being practiced out there. And so it's complicated and it's complex, and it's a shame that it is. And it really comes down to the exact same thing over and over and over again. If you're fortunate enough to create a relationship with a healthcare provider that you like and trust, the two of you discuss it and you discuss the risk benefits. And that's the core need, is that you go out shopping, hopefully proactive before you have to, and link up with a healthcare provider that you go, wow, I really like this person and I really trust this person. And they really seem to be sane and sober and spot on, experienced and educated and the whole 9 yards. And again, bottom line, I like them and I trust them. So I can discuss with them. And why I went down the sidetrack is there's many patients who've gotten a little scared by their provider because their provider's scared. They don't know the patient like they used to in the old days. And they don't know the patient's family, and someone could just throw a brick at them like nothing. So they practice, it's called defensive medicine. They'll do everything, they'll do all these tests because, so I know I've drifted into this. It shows the complexity that's going on out there. So that's the era we're born into. So we go with the complexity. And this is the things I can't advise this patient on is, does she trust her gynecologist if this gynecologist is involved? And if she does, and that gynecologist wants a biopsy, you go get the biopsy. It's rare that the cause of spotting is from endometrial cancer, but it does occur. I've seen 2 cases of it, and the women's lives were saved because the spotting was a signal to a very small endometrial cancer, and they caught it, and game over. They did the surgery. No one likes to do surgery, but you sure do when it saves your life, stuff like that. Caught it in an early stage, total cure. No need for chemo, no need for radiation. Caught it in an early stage. And yet over 99%, and I don't know the exact percentage, I'm sure gynecologists do, know that spotting is from inappropriate hormonal dose, or the presence of fibroids that are irritating that endometrial lining, or didn't get the progesterone adequate, didn't get a robust amount of progesterone to balance that estrogen. So, like every question you have ever posed on this years that we've been doing it, these are important questions, and there's some details. And what does it come down to? Go shopping and find a provider that you trust and do what they say. And it ain't perfect. Sometimes a provider says, you know what, my hunch is we need that endometrial biopsy to feel safe. And then it comes back normal. And you go, geez, I went through all that hassle to get a normal endometrial biopsy. And what I say to that patient is, yeah, you go out and celebrate that. Take someone out to dinner if you come back with a normal endometrial biopsy, because we can't call it perfect. No one can do it perfect. But if it's time to go get that endometrial biopsy, well, why would it be time? Because you have a healthcare provider who's been assessing that bleed, and you trust them. And that's the core issue. If you trust them and you like them and they say go get the biopsy, don't sit there and negotiate with them. It's a common practice these days for patients to negotiate with their providers. Over the years, I used to try and accommodate everyone, and I don't do that anymore. I say this is what we're going to do, and I don't mean to be too weird about it, but this is what we do. I'm not going to sit there and debate what's good medicine or not with someone, and it's fine if they don't agree with me, but I do not continue in a healthcare provider relationship with any patient who is saying to me, no, I don't want to do what you want to do. I say, that's fine. But you will need to find a health, like mammograms, for example. This is a classic example. And I'm not going to bust out into this subject, but in the menopause method, we insist on mammograms because we've picked up cancers that women had no idea were there and saved their lives. So when a woman says, I don't want to do a mammogram, I say, I understand that. This is a personal choice that you have. However, I will not be able to be your doctor. So, simple question, Carolyn. Oops.
As is always, simple question, simple answer. And we love these answers. And I got to tell you, these questions we get are off the charts. Really, they are.
Sophisticated. They're the right. These are the questions that need to be asked. I'm
Well,
am-
the
I'm
women want to know.
I'm amazed. All these years, I don't know that there's been a single question that you've ever asked that I thought, wow, that's a great question. They're all like that.
I know. It's kind of beautiful,
Yeah.
in a way. Women really wanting to know, and now we're talking about it, and it's not so taboo. And, I don't know how you made it through all those years, but we had to. Um, 50 years a doctor, 25 years of treating women in menopause, and I don't know how you did it, behind closed doors, I suppose. It was so hush hush.
With deep gratitude and a lot of effort, and we all have our place in this world.
Yes.
We matter to people, and we're out there doing it, right?
We
Whatever that
are.
is.
Let me ask this question. Yeah. Okay. So this is a good question from that question. Um, my provider does not check progesterone levels. My testosterone was at 23, but 3 months later, I was not checked for it. And this doesn't make any sense to me. I do use creams. My estradiol started at 4 and is now at 422. My estrone was less than 10 and is now 539. My DHA was 19, but now it's 10. Would it not be prudent to check other hormone levels?
Well, these numbers that this question is posing, these are blood test numbers, and there's when we assess a woman in her treatment program, we use multiple approaches to assess many aspects of a treatment program. And for a woman in menopause who's being treated with hormones, we do not use blood tests. I've used blood tests for 55 years. We do blood tests on every single woman. And we're gonna need to mute Carolyn, that we're getting the crackle. I do blood tests on every single patient, and sometimes a lot of them, but I don't test hormone levels in a woman we're treating. No, do not do that. Not ovarian hormone levels. For example, if a woman applied her cream, well, at the time she applied her cream, when do you draw her blood? Do you draw her blood just before she applied her cream? Do you draw it a half hour afterwards, 2 hours afterwards? It's not like you can't learn something. You can, but this is called pharmacokinetics, and how fast does this stuff absorb into the bloodstream, and how long does it stay in the bloodstream, and how steady are those levels? Well, all these technical challenges in assessing hormone levels are totally cured by collecting urine for 24 hours. State of the art. Want to understand a woman that you're treating with hormones? Do 24-hour urine hormone collections on them. You'll get just wonderfully accurate and useful levels. So the blood test numbers you're telling me don't have enough specificity to them to be able to evaluate. Now, I recognize that some of those numbers are quite high, so I would go out and go shopping and find a physician or a nurse practitioner or a prescribing compounding pharmacists who are specializing in treating women in menopause with bioidentical hormones. Because there's a deeper assessment needed here. One thing is symptoms. Are you having symptoms of too much? Because that's what some of those numbers are suggesting.
So please allow me to interrupt here, because she did go on to say that estriol is not used, nor the 24-hour urine testing, and I'm having really increased fatigue, headaches. My primary care physician, who's not the prescribing physician, shows that I'm within normal and good ranges, although I'm totally confused by this. And also I'm getting foot and leg cramps again. Sigh, she writes, so she is symptomatic.
Well, here's what we accept when we treat women or men in menopause or andropause with hormones. They feel better. And symptoms that are related to insufficient hormones are alleviated, and they don't develop new symptoms. And when we test them in a proper way, they fall into optimal ranges as defined very carefully by the science behind hormone levels. And other parameters of assessing them fall within really acceptable ranges. For example, in treating women, that our mammograms are normal. Sometimes we even do thermograms. That our transvaginal ultrasound, when called for, are normal. That our bone density is normal. Between symptoms of hormonal insufficiency or hormonal excess, as I describe in great detail in our book, Happy Healthy Hormones, which Carolyn has made available, a free PDF copy of it on Facebook. Through symptom evaluation, through 24-hour urine hormone testing evaluation, through evaluation of such things like sex hormone binding globulin in the blood, also assessing the thyroid and other normal blood tests. Through mammograms, when needed, transvaginal ultrasounds, thermograms, bone mineral densities. Proper treatment of women in menopause includes looking at all of these issues. And I assert it's not really possible to do anything but guess if you're not doing 24-hour urine hormone tests. Now, having said that, there are a lot of healthcare providers who prescribe some pretty standard dosages. For example, there was a lot of Premarin and Prempro being prescribed prior to 2002, 18 million American women. And even, and even though there was only a couple of dosage forms, and even though the majority of those women did great, so even taking a guess at it works pretty well for a lot of women. The women who were treated with Premarin and Prempro, 18 million American women in 2002, most of those women did fabulous and a lot better than their counterparts, their contemporaries who were not being treated. So hormones are powerful. They're some of the most powerful biochemicals in our body. Their insufficiency has long-term consequences of the worst, osteoporosis, sarcopenia, that's loss of muscle mass, leads to Cane's walker's wheelchair, loss of vagina, loss of bladder, loss of cognition. Oh my God, insufficient ovarian hormones have dire consequences in most women, especially over time. And as we've said many times, your life is going to matter to as much to you when you're 70 and 80 and 90 as it does right now in this moment. So hormonal insufficiency has dire consequences. Hormonal excess is not a good deal. And to get it right, the best thing you can do is go shopping and find a healthcare provider who's specializing in treating women in menopause with compounded bioidentical hormones. Yeah, same thing. I love to repeat that because that's what it comes down for you. You gotta do your research. You gotta find the person. And it's easier these days because of telemedicine. They don't need, so long as you have a primary care provider who will do periodic female exams, or a gynecologist who will do that. You don't need to see the hormone specialist in person. You can see them on your computer or your phone via telemedicine. So you have access to any licensed healthcare provider in your entire state. Ha! That's great. So it's much easier to find people who are specializing in this these days. So, there you
Well,
go.
we did have a question that came up pertaining to that question
Huh.
from Rod saying, so could that mean that cortisol level is spiked if one is getting all of that?
I'm not understanding that question. If one is getting all of what?
Well, I'm not 100% sure either. However,
I can answer this question that is not understandable, really. Um, there's just not enough information there. But cortisol levels do spike, especially in younger people who still have the adrenal power to get robust cortisol levels to occur. Cortisol is one of the most important hormones in our body. It has critical daily functions. You can't remove the adrenal glands and live because you must have cortisol, and cortisol is produced in the adrenal glands. And at the same time, young, healthy people can put out extra cortisol because cortisol can be recruited for the fight or flight response, the biology of the stress response. And it leads the pack along with adrenaline. When you get attacked by a saber-toothed tiger, or you're freaked out about your cash flow or whatever else is upsetting that day, you do the same thing. Saber-toothed tiger, bank account concerns. You put out the fight or flight hormones. And at the head of the pack of the fight or flight hormones, many are used, are cortisol and adrenaline. So young people with healthy adrenal glands are pumping out excessive cortisol frequently, especially if they don't have other skills to respond in a beneficial way to the stresses of life, and they just more lean towards freaking out. And you keep doing that day after day after day, there's a lot of consequences of excessive cortisol. A lot of them. And as time goes on and you get older and you keep putting that kind of pressure on your adrenal glands, your capability of getting cortisol spikes lessens and lessens and lessens. And eventually you'll get so that you can't even put out normal levels of cortisol, even when stressed. So that's a general answer. Cortisol spikes are very common. If you're really skilled with your emotions and your mind and your ability to make proper choices, you can really minimize the number of cortisol spikes. You don't need the biology of the stress response. And this is knowledge, tools, information, choices. It's a wonderful body of knowledge to have. How to respond to stress, how to respond properly to the stresses of life. But at this time in human history, which happens to be an extremely primitive time, just look around us and see how much jeopardy this planet is in. And yes, there are millions of folks who are caring about becoming better people, wiser people, kinder, more golden rule-ish people. That's the great news in America. There's millions of people who are really putting in their shoulder to the wheel to really improve their relationship to their own emotions and their mind and the choices they're making and trying to get more skillful and beneficial in relationships. But that's not the only thing going on here. There's a lot of chaos and there's a lot of blaming that has nothing to do with life, is inaccurate, and is extremely damaging. So that's a whole other topic. But if you stress in life is normal, it's valuable, it's an important part of living on Earth. But it does matter that your skill set continually improves over the course of your life, so you get better and better and better, and wiser and wiser and wiser how you respond to the stresses of life. And if you get really good at it, you're not going to get these cortisol spikes and wear down your adrenal glands and screw up your immune system and gain weight, because you're going to get insulin resistance and you're going to gain weight and you're going to put it on your belly and your thighs and your butt and places you don't want to put it, because you're putting out excessive amounts of cortisol. So cortisol spikes, it's a big topic. I'm just giving you the general overview of it.
What's beautiful is that, you have brought a lot of that information into us. And when we do talk about the change of life, you've enlightened us to what can be involved with that change and how we can accept that change in a really helpful way by doing many of these things that you do suggest. And that's not for this interview, but we've done many interviews where you've introduced us to some really amazing ways of, yes, taking care of, that fight or flight response in the middle of the night with the saber-toothed tiger that you and I ran into millions of years ago when we met. Yes, I well remember.
You're revealing our age, Carolyn.
I don't mind being 9 million years old. I don't know about you, but I feel pretty good. And you look pretty good for being, what, 10 million years old? If I'm 9 million, you're 10 million. Yeah, it's all good.
I guess,
Um,
yeah.
so we can reveal our age. It doesn't matter. What's a couple of million here and there, right?
Right.
Um, Here we go. I have gained 5 pounds since I raised my estrogen patch from 0.4 to 0.5. My E estrogen is still low, but how the heck did I gain this weight so fast?
The usual cause of weight gain that's super common is when a woman is in menopause, she hasn't been on estrogen, she starts estrogen, and she immediately gains some poundage, and that's usually water weight because estrogen is very critical for maintaining proper hydration. And women who haven't had estrogen, for example, you can really see how dry their skin has become. Thin and dry and doesn't look like a 20-year-old woman's skin, which is beautifully hydrated, and estrogen plays a role in that. And I just had a consultation with one of my patients yesterday, and she was just ad lib describing to me some of the changes she's had. And she said, God, I used to have dry eyes and dry skin, and now I'm totally restored to what I was used to when I was young. So the usual thing that happens is you gain back the water. You're gaining back the water. You're not gaining necessarily adipose tissue poundage. You're gaining water weight. Now, there's a lot of weight gain that can occur midlife in men and women, and that is not. And of course, this questioner talked about a minor tweak of the dosage and a rather significant weight gain. So I'm not going to attribute it to that general answer that I gave, because she's already on the patch, which is an estradiol patch, and she gained some weight, a significant amount. So the initial explanation I gave that that's from estrogen is unlikely to be the reason. And the best I can come up with is the uncomfortable challenge of arriving at midlife and putting on weight. And this is occurring sometimes for obvious reasons, and a lot of times you're dealing with people who are being careful, super careful around what they're eating and their exercise, and yet they're still gaining weight. And weight gain is complex. And we have a whole chapter in our book, Happy Healthy Hormones, on weight. And that's not even the final answer. There's other moving parts. But really, when you're gaining weight, it's a body of knowledge that needs to be used to examine and find the multiple reasons that are involved. And where you look, in general, is what are you eating? When are you eating it? How well are you digesting? Are you overeating? And are you stressed and putting on a bunch of stress biochemistry, like that cortisol we were talking about and that adrenaline that leads to insulin resistance? And we go into some depth in the book about what insulin resistance is, which is the perfect recipe for weight gain. And what's your hormonal balance? Because in order to have proper metabolism, what metabolism is about is you eat food and it winds up in the cells and it goes through biochemical transformation, colloquially known as burning that food. And so you eat the food, you burn the food, and you store some food, and that's what you do. And that's called metabolism, one sort of metabolism. And if you're not efficiently metabolism, you take a lot of young people, not all young people, man, they are just supercharged Olympic metabolizers. So they can eat and eat and eat, and they're not necessarily going to gain weight, although that's changing in the course of my lifetime. A lot of the young people even are getting an adult type of diabetes, and they're gaining weight outrageously, and that's usually from diet and stress. So these are the various things that need to be looked at. So I've heard many cases of where women said, all of a sudden, midlife, I'm gaining weight. And how I look at it is, no, there was years and years and years of challenges to that exquisite glucose insulin regulating mechanism and everything that relates to metabolism. And then all of a sudden, what was once normal function of metabolism went off the rails, and it looks like it was instantaneous, but it took years of assault on that mechanism that controls weight for it to finally say, I can't handle it anymore. And you start putting on weight. And the many moving parts need to be addressed. So there's a lot of people paying a lot of great attention to this. And there's a lot of information on the internet alone that's really high quality and speaks to all the things that can happen midlife, including hormones that need to be looked at and addressed. It always comes down to the same thing: nutrition, exercise, too much or too little, how you're doing with the stresses of life. Are you doing a weight neutral response to stress, or are you doing a weight gain response to stress? Which relates to the hormones, it ties into the hormones. And then, what did I leave out? Toxicity, yeah. You can have toxic exposures that are screwing up your metabolism as well. So you need to detoxify. So weight gain, a lot of moving parts there, and yet it's so common to hear, God, I was maintaining my perfect weight, and then all of a sudden I started this or that, and I started gaining weight. I gained 5 pounds overnight. Well, it wasn't overnight. It was for the causes that eventually translated into gaining weight developed over 5, 10, 15, 20, 25, 30, 40 years. And then there was the final straw, and boom, couldn't control the weight anymore, and on it came.
As you said, lots of moving parts.
Yeah.
And I could see it speaks to what we were talking about earlier of, doctors and med malpractice and not having time and taking on this huge specialty called menopause, which is almost close to impossible when you're 3/4 of the way through your career, specializing in whatever. So, my hope and your hope, I know, for 2022 is to do as you said and have many, many, many more doctors very passionate about helping us women in menopause. And I know that's going to happen. I do. And I have a good feeling that a lot of people are going to be feeling really well, men and women both. And I'm really happy about that because it's something I really love to do and learn and know and help with your help. Thank you.
I love your deeply positive streak. Your
Oh,
bottom line, Carolyn Shapiro.
I didn't hear that. I'm sorry. What?
Your bottom line, in my observation of you, is a deeply positive, optimistic, positive grounding. That's where you originate from. That's the gift you bring to all of us. One of them.
Well, you know, thank you. Kind of can't help it. So I figure I'm not going to fight it. I'll just go with it. And the universe shone really kindly on me. It sure did. Oh, did it ever. So I have a lot of gratitude. And yes, this is not unlike you, what I love to do. And I'm very blessed to be able to do what I love. Yeah, nothing better than that, right? So, how is it that my DHEA can be so high without my supplementing? Is there a remedy for this, Dr. Rosensweet?
Well, it's not a common thing, and I have run across it. It was in a young man, and we did some very serious investigation of why his DHEA was running so high. And eventually the conclusion was it was a genetic thing. It was not an abnormal thing. And that's what was so in that young man. You know, I can imagine other causes. And in this young man, we wanted to rule out the other causes. Like, for example, you can have adrenal tumors, benign and non-benign, that can produce extra hormones, excessive hormone levels. And we'll take the steps. When we see a high DHEA, there's a medical path to investigate, well, why is that high? And whenever something is not, quote, normal or reasonable, I always ask the question, well, what is it that we could miss that if we missed it, it would be deleterious? Let's not miss it. What do we need to do to make sure we investigate it and don't miss it? So when you see a high DHEA, you got to get a hormone specialist. And sometimes those hormone specialists are endocrinologists, and they know how to investigate and, for example, rule out adrenal tumors, because that can be a cause. One of the most dramatic causes I saw was in a menopausal woman. We did a 24-hour urine hormone test on her, and we saw high cortisol. And I thought, this is going to be the second adrenal tumor I've uncovered. And because it was very high, the adrenal glands also put out other hormones, DHEA, for example, testosterone. So when I saw that high level, I set her up. I set her up for an MRI or a CAT scan of her adrenal glands to make sure she didn't have a tumor, because it was really dramatic. And then I had this flash. I asked her, "Gee, are you taking any nutritional supplements?" And I asked her, this was via telemedicine, to line up on a table every single nutritional supplement she was taking. And indeed, she was taking a lot of them. And indeed, she was taking a supplement called Adrenal Support. Nutritional supplement. Adrenal Support. And what's known, when I saw that, I said, okay, here's the next step. When in doubt, stop taking everything that you can actually stop taking. Let's see what happens. She stopped taking all of her nutritional supplements, and her cortisol level reverted to normal. So instead of getting the MRI, God knows how much that would cost, or cost the insurance company, she just stopped all of her supplements. And what did that point out? That those supplements had been spiked by cortisol, because people can really feel cortisol, and it's been a rare but deleterious practice of some out of integrity supplement producers that have existed throughout time, that they don't mention on their label that they've spiked their glandulars with actual hormones. And that's how she had that high cortisol level. So I'm not saying that's what's happening to you with the high DHEA, but it's a real easy thing to do. So what does it require? Medical investigation, starting with sticking all your supplements up on a table and reading the label. And if they see anything that even hints at glandular support of any kind, like adrenal support or thyroid support or anything like that, you stop them and you see if you still have that. And sometimes we have to go further than that. I saw one of those elevated levels once of adrenal hormones, and I'm even forgetting which one it was, and I was concerned about it. And eventually we did do, either a CAT scan or an MRI of the adrenal gland, and there was a very small tumor there. And the anesthesiologist commented to the patient, because we had picked it up on 24-hour urine hormone tests, that periodically, because they're hanging out in surgery, they see patients who have adrenal tumors. And the anesthesiologist commented that that was the smallest adrenal tumor ever found. In other words, it was caught really early, and that was caught on a 24-hour urine hormone test. So one thing I would like to say right away is, you need to investigate all these things I've mentioned, including doing a 24-hour urine hormone test. And again, on a young man, he was in his 30s. He had a definitely high DHEA, and it turned out to be he was of a certain European country descent that was known to have occasional high uh, DHEA levels. In fact, his brother had an elevated DHEA as well. So if you just got a little bit befuddled by the amount of information I said to you, questioner, it comes down to one thing. If you have a high DHEA, you want to start following the bouncing ball of investigation to whether to, and you need someone who knows how to do that. Many endocrinologists do, some don't, because it's DHEA. But this is endocrinologists know how to find unusual things. They have the tools, so you might need to start there with an endocrinologist. And you want to catch those things because most adrenal tumors, if that's the cause, I'm not saying it is the cause with this patient. If that's the cause, you catch these things early, you get total cure. Even if they're cancers, which are very rare, but they occur, you get total cures. Total cures are fun. And the earlier you catch this stuff, the better. So,
We love total cures. They're very fun. I enjoyed mine for
yes.
sure. Enabled me to just keep it moving. So here we are, and I know we only have a few minutes left, so I'm like going back and forth here. A woman writes in, and thank you for that answer, by the way. Um, oh, she writes in, if a woman has a level of 0.3 for progesterone, does she still need hormones?
Well, we're talking about a blood test there.
We are.
And a woman needs progesterone. And there's a misconception out there that women who've had their uterus removed do not need progesterone. That's, in my opinion, wrong. Progesterone is a very, very important hormone for women. Very important. In fact, in young women, there's 100 times more progesterone each month than there is estrogen. Estrogen is a critical, important, crucial hormone for women, and there's 100 times more progesterone than there is estrogen, milligram for milligram. Women need progesterone, and women can start losing their progesterone, adequate progesterone, in their 30s pretty easily. Progesterone, for various reasons, can decline earlier and deeper than estrogen declines. Women peak out on their hormone levels at the age of 20, plus or minus a couple of years. And from that moment on, they start declining in their ability to produce ovarian hormones. And let's just look at estrogens and progesterone. The progesterone can decline deeper and earlier than the estrogen is declining. It's very common to do so. So if a young woman in her early 30s is starting to get symptoms of cramping or breast tenderness or not sleeping as well or irregular periods, she can just get progesterone even over the counter and bring back her progesterone. You want progesterone, you want it all your life. Progesterone is the only substance I know that stimulates osteoblasts to lay down new bones. New bone. Yeah. Prevention of osteoporosis. Progesterone has major beneficial effects on mood. Many women who have anxiety, there's a chemistry to that anxiety, and the core chemical thing happening there, she doesn't have enough progesterone. Now, I'm never going to say that emotional dysregulation is about better living through biochemistry. It's not. The emotional origins are not just biochemical, and the causes are not biochemical. Biochemistry will show up according to what's going on multidimensionally. There's a statement. I'm not going to go into it right now. But progesterone, progesterone, progesterone. Yes, yes, yes. And because for a long time, progesterone was so much thought to do with the endometrial lining and only the endometrial lining. Therefore, if a woman had her uterus removed, she did not need progesterone. Wrong. Progesterone has a multitude of functions, just like all these hormones do. So any woman, every woman, midlife, we're treating with progesterone. Hysterectomy, we treat women with progesterone, absolutely. Just like we do women who are in menopause and not producing enough progesterone with a uterus. Progesterone, progesterone, progesterone. It's wonderful stuff. It's important stuff. And oh my goodness, it's time once again. I don't dare go into answering another question because it usually takes me time. You may have noticed that, Carolyn. That it usually takes me time to answer questions.
And if you think that I mind that, you are sadly mistaken. And I don't think I have one woman who comes up here or man who minds that either. So I would never be apologetic, Dr. Rosensweet, about that.
All
Nope,
right.
nope, nope. So another interview in the bag. Great information. Thank you so much. Thank you, ladies, for coming up. Everybody who did, got your questions for Thursday. And we will be back at it. And I hope everybody has a really great day. Laugh a lot.
Happy New Year, everybody.
And Happy New Year, everybody. And Dr. R, thank you so much always.
You're welcome, Carolyn.
See you later, all.
See you Thursday morning.
Bye.